first?
We've got several for you. Some of them we can't read the handwriting, but
Just like a physician.
that's right. Why don't you go first? I got a couple, a few more there.
So there's a question about osteoporosis. In my world, because remember, many of our effective drug therapies as the disease advances work by cutting out male hormone or female hormone in breast cancer. So the good news is we can stop the growth of your cancer by putting you into menopause, a man. But the bad news is the man experiences menopause in about a month or 2 months, whereas women get anywhere from a year to 5 years to experience menopause naturally. Men on this drug experience it immediately. So they have all the signs of menopause, including accelerated bone loss. In my world, lifestyle is not just about heart disease, it's about almost everything, which means I get excited about osteoporosis drugs when lifestyle, which means a normal vitamin D level, calcium intake, lifting weights 2 to 3 times a week, being aerobically active, when you do all these things and you're still losing bone density, it's probably a good indication that that's not going to work, so you might have to go to a prescription drug. The problem with the prescription drugs in Canada and the United States right now for bone loss is what I see is a lot of people put on them before they've had a 3 or 6 month trial of lifting weights and taking supplements and being active. So we had a very famous study by a drug company done last year, published in the New England Journal of Medicine. Because normally in bone loss studies, the placebo group doesn't do anything. They just sit there like a bump on the log. And so they're going to lose bone mineral density. So we have a new drug. It's a monoclonal antibody. It's been approved for prostate cancer and to be used for bone loss. And then they did in this study was they had the placebo group get a normal vitamin D blood level, take calcium, 1,200 milligrams a day, and they were physically active. And the amount of bone they lost was about 1% over 2 to 3 years, which is completely opposite of what we were taught. We were taught 5 to 10%. But the good news is if your doctor puts you on an osteoporosis drug, if you do lifestyle changes, heart-healthy lifestyle changes, you do lift weights and the doctor says you can lift weights, and you do normalize your vitamin D and take calcium, it only makes the drug work better. It's no different than a cholesterol-lowering drug. If you continue to be heart-healthy, it makes your cholesterol-lowering drug work better. So I'm a big fan of the osteoporosis drugs, someone asks, like Actonil, and also the IV drugs, but I'm especially a big fan of those osteoporosis drugs if you are also lifting weights and doing the things I told you, because it will make the drug work that much better. Now that being said, these drugs keep giving for years and years. So it's always important once a year or so to go back to your doctor and say, can I take a drug holiday or do I need to continue on this drug? Because these drugs stay in your body for years at a time. So the question to ask your doctor if you're on an osteoporosis drug after every yearly visit is, do I need to stay on another year or can I take a holiday? And you make that decision with your doctor. So hopefully that answers that question. That's one of the most common questions I got when people were coming up to talk to me.
So there was a question, what causes PSA level to rise? So there's lots of things that can contribute to PSA. So PSA is a protein that's found in the blood that's made by the prostate, and it's made both by normal prostate cells as well as prostate cancer cells. So just about anything that in a man whose prostate is still in his body, just about anything that can perturb the prostate can put the PSA levels up. So small rises in the PSA can be seen as men get older and their prostates just get a bit bigger as they age. So a normal PSA level will change as a man gets older. If a man has benign enlargement of the prostate, they can get a PSA level that goes up. If there's an infection, that can put a PSA level up. Even things like bicycling for long distances have been noted to put the PSA level up. And finally, the presence of prostate cancer can as well. So that's one of the challenges with using PSA as a blood marker to detect prostate cancer. There are so many other things that can affect it. It's trying to find that signal that makes you think there's some cancer in there, in the noise of all the other things that can affect PSA. So PSA is a very good marker when you know there's prostate cancer there, a very good marker to follow prostate cancer, not such a great test if you're not sure if there's prostate cancer, and that's where all the controversy about PSA screening comes in. In the same way as there's calculators to calculate your risk of heart disease, there's calculators to calculate your risk of prostate cancer, and these are more nuanced ways to use the PSA to estimate your risk of cancer and whether you should be looking into it with other tests like a biopsy or such. But it's really, it's not a simple answer about PSA, when to check it, and it really is the sort of dialogue to have with your doctor in the context of a regular health exam when you're looking at the whole big picture. But the simple answer is that there are lots of things that can affect the PSA, so the assumption shouldn't be right off the bat that it's cancer.
And being a urologist, I can just add that if you do a rectal exam, that can make the PSA go up a little bit as well. And when we often see patients with one PSA, we always tell them, you know, probably, if it's isolated and no previous history, then tell them they need to, the best to just repeat it to make sure that it is consistent as a real finding. Sexual activity can do that, so we actually recommend that people be abstaining for at least 48 hours before getting a PSA, or if they already had a PSA done and then unexpectedly came back as being high, one of the first questions we ask is, you know, did you engage in sexual activities the night before and so forth, and if so, just repeat it, and then see if in fact there's a real change. Mark, you've got more questions. Maybe I'll get you the next one.
Oh, it just reminds me of a story. I always get the question, hey doc, what's going on with sex and prostate cancer? And I say, well, I just can tell you what the largest study ever done. That was 2007. It was in the Journal of the American Medical Association. It was a study from Boston, actually looking at healthcare professionals, and they found that there were only one group of men that had a reduced risk of the disease, and these were men that reported over a 10-year period 21 or more ejaculations per month. So in the press, CNN, I had to do a press conference, and my answer never aired on TV because they didn't think it was funny. So they said, well, what do you think about the study that shows 21 or more ejaculations per month reduces the risk of prostate cancer? And I said, now I'm convinced that lying reduces your risk of prostate cancer. I don't believe this. I said, these guys are making up this story. And just so you know, if it's true, it came from whether it was self-induced, whether it was sexual activity, but it does seem, it either shows a neutral effect or a beneficial effect in that category. As far as a question, I get a question on B12. Vitamin B12 is promoted all around North America to give you energy, and people go in for vitamin B12 shots. But the truth of the matter is, the original recommendation that vitamin B12 might help patients comes in from about 50 years ago in people who were anemic, that had very low levels of B12. So on a blood test, their B12 and some other markers were so low that without getting B12 from an injection or actually a pill, then they would become anemic. The problem is we really don't see that as much anymore today. So if you're really curious about your B12, there are not many vitamin tests that are actually worthwhile. So let me repeat that for you in case you ever get suckered into getting a lot of vitamin tests. There are very few vitamin tests that are that good. Why? Because we haven't studied them long enough. So just because a vitamin test is normal or abnormal doesn't necessarily mean it's going to benefit you or not. There are exceptions. The vitamin D blood test I talked about seems to be okay. We have some issues with it too. And the vitamin B12 test seems to be okay in terms of predicting who's deficient or not. But just so you know, scientifically speaking, vitamin B12 as a pill for most people works as well as an injection if you ever need it, and you're going to save a lot of money. As far as vitamin B12 and prostate cancer is concerned, the two B vitamins we're very concerned about people getting way too much from pills is actually B12 and folic acid. Folic acid is also a B vitamin. But if you're really concerned, you can go in your primary care office, and if you've never had a B12 level pulled, like an iron level, it's actually a very accurate test. You can ask about it. But I see people taking these massive quantities of vitamin B12 all the time because someone said that it can inhibit cancer, or it improves your memory, or it does improve your energy level. That was true 35 years ago. But now we've added so many B vitamins to the food supply, it's very rare to actually see a benefit unless you're outright anemic because of a low B12 level, which I hardly ever see anymore.
I guess I'll do one first. This one says, my father died of prostate cancer. My father-in-law died of prostate cancer as well. Now, as far as I know, father-in-law, your wife's probably doesn't affect your wife, your father-in-law, but I could be wrong. But and then it says, my 3 sons, I have 3 sons, any words of wisdom for my 3 sons? Now, I'm not sure, you didn't say whether you yourself had prostate cancer or have. Certainly, father, and assuming that you yourself also had prostate cancer or have or had, then your risk, your offspring, your 3 sons, the risk is increased significantly, probably about 5-fold. I could be wrong by a little bit there. Certainly 1 first-degree relative is increased about 1.5, 2 times, and then if you have 2 first-degree relatives, that's assuming both you yourself and your father. So for the grandchildren, they're at 5 times risk. What should we be doing? Well, they should be checked, and fortunately we do have the PSA tests, which I know you're aware of the controversies and so forth, but it is still an extremely good test in terms of knowing whether the numbers are in the worrisome range or not worrisome range. So they should actually have a PSA in their relatively early age. The recommendation is, if you have that strong a family history, is probably at age 35. 35 or 40, they should have at least 1 PSA and see what it is. If it's a very, very low range, then they're actually okay for a few years. They don't have to have it every year for the rest of their lives. But if the PSA is up a bit for their age, because it's so-called age-adjusted, if there's a bit up, then they should actually have it more frequently, like once a year or so. So the advice is that they should be checked. Certainly their physician should know about that. They may want to refer them to a urologist for assessment, but certainly a family physician starting around between 35 and 40. I don't, any other comments on the age range and so forth?
No, the only thing I would add to that is I get this question all the time. People come in and they'll say, I have this, and I'll say bring the family in. They'll bring this huge history of prostate cancer, and none of the kids will have ever had a cholesterol test. And that just makes no sense to me. And that's why I tell the kids, look, take your cardiac risk to close to 0 as possible, and then we'll start talking prostate because it's already going to pay off for that area. What I told a couple of people who asked questions is, cholesterol lowering is working as the perfect preventive drug because it's not really lowering the risk of you being diagnosed, but it's lowering the risk of aggressive prostate cancer if we think it's working. We've had 2 very famous drug trials in North America to prevent prostate cancer, and both came with controversy. One was finasteride, a drug that seems to lower the risk of prostate cancer. It's a drug for prostate enlargement, and it lowered the risk of prostate cancer, but may have increased the risk in some rare people of a high-grade tumor. So on one hand, it's lowering the risk of prostate cancer, a non-aggressive tumor, but on the other hand, in some people, it might be increasing the risk of an aggressive tumor. Either way, it's controversial. In that study, in the placebo arm, the men with the lower cholesterol had about a 60% reduction in the risk of being diagnosed with aggressive prostate cancer. That should have been a headliner. Then a big study done with Avodart, dutasteride, they reevaluated those results. They found that the drug might reduce the risk in high-risk patients. But they also just found that men that had normal to low cholesterol and the lowest risk for heart disease had some of the lowest risk of being diagnosed with prostate cancer in that study anyway. And those are 2 findings from our 2 biggest drug studies that never really got too much attention. So I mention that all the time, same thing I do to breast cancer patients. And then let me just give you a comment on the PSA screening. I know it's controversial, but this also goes along with screening. In the North American or American study, a friend of mine from Colorado did an analysis on the screening study and published it last year. And they found that the healthiest men who were screened with PSA had the greatest potential benefit of having their lives saved. Think about that. The healthiest men who were actually in the screening study, the PSA controversial screening study, the healthiest men actually reduced their risk of dying for prostate cancer if they had a PSA test, which actually makes sense. If you're really healthy and you expect to live to be 100, then that test can really save your life. If you've got 20 other diseases going on and you're 88 years old and you think a PSA is going to save your life, you've got 20 other things to worry about. The chances that a competing cause of mortality or death is going to get you sooner is very high. So the one thing that we learned that should have been brought out in this controversy is that if you're a man that really takes care of himself and is really healthy, PSA still looks pretty darn good. But if you've got a million other problems going on, you're not heart healthy, you've got other problems, it's probably not going to pay off, which is the same advice I give in breast cancer. That's the same thing we found in breast cancer. If I have a 65-year-old woman who's dealing with 7 other diseases, multiple surgeries, multiple other diseases, and is too concerned about a mammogram, I don't know if that's going to pay off, but if someone who's 65 is completely healthy gets a mammogram, the chances that will save her life are very high. I think that's what's going to come out in all this screening debate, is those that are very healthy will really benefit, and those that have other risks or other things that will take them off of this earth in the next 5 years won't benefit.
Of course, your perceived risk is probably a bit biased. Everybody probably thinks they're pretty healthy, but
absolutely.
Not
no, everybody thinks they're healthy. That's true.
So everybody wants the PSA. The question from this question was: as prostate cancer patients, by educating ourselves, can we actually help the doctors to help us? And if so, in which ways can we do that? So, I think one of my observations is it's a little bit like complementary medicine. I mean, at the very least, we'd like to know what you're looking at. At the very least, we want to know what you're taking. We may not be able to tell you if this or that is the best for you, but we at least would like to know. Okay, well, where are you getting your information from, and we can maybe advise you if that's a reputable source or a recommended source. And there are, when you're educating yourself and looking these things up, there's so much, especially on the internet, so much available, and you can get sucked into so many corners on the internet, and you've alluded to all sorts of sort of misinformation that's out there. I think the best thing you can do is have a dialogue with your doctor and say, look, I've really found this to be a helpful site, or this is what I'm looking at, and we can also help point you to sites that we think are helpful or useful, and there's lots of good ones out there where we know the information's of high quality.
No, you just reminded me of something. When we were looking at the Andorra population, the population with the longest life expectancy, there were actually people getting prostate surgery in their 80s and almost 90. And these are people that had actually no other disease. They never dealt with any disease. I thought it was interesting that surgery was still an option and radiation was still an option in people who were 80 and 90 who had nothing else happen to them throughout their entire life except that moment where they were diagnosed with prostate cancer. So pushing this life expectancy envelope is going to be amazing. I mean, who knows where this is going to go, but I get a question here about getting wheat. This gluten-free diet, it's become a fad to go gluten-free. And we have tests to determine whether or not you have celiac disease, where you have an allergy to a protein, essentially, that you can find in wheat, barley, and oats in some cases. But I see people go on gluten-free diets all the time who don't have the disease or sensitivity to gluten. They just want to go on a gluten-free diet because they want to try something different. But you have to understand that I don't think that's a bad thing. Like I said, I really believe you should pick the diet that works for you. But you'll notice that when you eliminate a lot of these products that have high concentrations of wheat, some of them are very high in calories. And so people become more physically active, they reduce their caloric content, and they slowly lose weight. So it's like someone going on a diabetic type diet who's not diabetic. I don't lose any sleep. I think it's ultimately healthy. So if someone wants to try a gluten-free diet who doesn't have the condition, and if it helps with weight loss, good for them overall. I just want to caution you on wedding diets, or what I call high school reunion diets, where an event's coming up and someone's just simply going to starve themselves, or they're going to work out like crazy and they're going to lose weight. And it does work, but you got to keep something in mind, that when you lose a tremendous amount of weight quickly, the body doesn't discern between fat and muscle. It pulls just as much muscle from your body when you lose weight as it does fat. So that's why if you've ever seen anyone drop 40 pounds or 60 pounds quickly, they might look thinner, but they've also lost a tremendous amount of muscle mass. That's one of the reasons why I don't encourage really rapid weight loss, more slow and methodical, because you can maintain your muscle mass that way. Because once you lose your muscle mass from an extreme diet, it's very difficult to get back to muscle mass. It's easier to get back to fat, but more difficult to get back to muscle mass.
Okay, I have one here. Somebody's had the prostate removed in April. He's getting better urine control now. And he says in the last month he started working out in the gym and using a vacuum pump as well for erectile function. But since then, the bladder control has worsened. And the question is, could any of these be contributing to the worsening of the urine control? Well, probably the working out in the gym does, in terms of just more exertion. The bladder or the sphincter muscles still haven't completely adjusted, and so now when you're working out in the gym, obviously you're exerting yourself more, and there's more pressure just coming from the top, and the just the differential in the pressures makes you leak more urine, at least for now. I would suggest you continue to work out and you improve in both ways, and but also keep doing the Kegels exercises and so forth, so that would help with the external sphincter as well. As far as the other issue, the penile pump, I don't think that would be contributing too much to this urine problem. But if the urine problem does continue to deteriorate rather than improve, then I would advise that you see a urologist or the surgeon who did your procedure. It's occasionally when things heal, they don't quite heal the way we expect it to, and actually it may be a easily correctable problem, some scar tissue or something that could be dealt with. Okay.
I go to the surgeon all the time when someone's had a prostatectomy and say, is this person fit to even move or exercise? And when they get the green light, that's when I do it. I mean, the idea is someone wants to run back out there, but everything's still very delicate. We're looking at a study right now that was done in Korea, and they just presented. We're about 8 weeks out of a radical prostatectomy. I'm actually going to discuss these tomorrow, grand rounds. About eight weeks after surgery, if the doctor allowed it, they were allowed to use a Bosu ball, or a ball that's, you see those big balls in the gym where you essentially, they're very squishy. You can sit there and do sit-ups. And essentially these patients just did core exercises. All they did was very minimal exercise to strengthen their core, to strengthen basically their back and their stomach muscles. And they're claiming a striking reduction in incontinence rates. So we are asking them, we're looking more at the data, but I do think there might be something with that, where there's more of a focus on core exercises when the person's recovered maybe 8-10 weeks out and the surgeon says it's okay. But they're not lifting weights. They're not straining that area. Like I said, they're basically sitting on the ball and doing sit-ups. They're holding the ball up against the wall and doing different types of exercise that actually work the abdominal muscles and the back muscles a little bit. And my hope is that we'll come up with some routine there that will actually improve patients further. And I think there's some promise in that category. Aspirin. So aspirin, this person says, doctor said take aspirin, adult aspirin every 2 days. Aspirin thins your blood for about anywhere from 5 to 7 days. A single aspirin can do that, which is why a lot of surgeons will say stop aspirin a week or two before surgery. I just want to keep something else in mind, that fish oil pills can also cause blood thinning. The problem with fish oil is that we can't predict who it's going to cause blood thinning in and who it's not going to cause blood thinning. We don't have a test for it. It's not a quantitative effect. It's what we call a qualitative effect. So I've seen people take 30 fish oil pills and they don't bruise at all. I've seen someone take one big fish oil pill and they bruise easily. So just keep that in mind. If you're taking aspirin, you might be adding another blood thinner to that. An aspirin every 2 or 3 days. An aspirin every 2 days is based on a study where it seemed to work as well as almost every day with less side effects. But if you have a really strong cardiovascular history, your doctor's not going to be comfortable with that. They're going to want you on aspirin every day. The big question with aspirin, when you talk to your doctor, if you need to take aspirin, is do I need to be on the regular strength aspirin, or can I just switch to a baby aspirin? Because we've noticed with a lot of people, a baby is just as effective over a long period of time with less side effects. But there are always exceptions to that rule. I find it interesting that even aspirin, like most supplements, like most pills, we used to recommend a really high dosage, and now we recommend sort of a moderate dosage that works just as well. It's a nice little lesson. I'll caution you, though, about aspirin and prostate cancer prevention, that unless you get the green light to take aspirin to prevent heart disease, I would not just solely take it to fight prostate cancer, because unlike cholesterol-lowering drugs or ones that affect your blood sugar, we don't have a good test in healthy people of taking aspirin of when something disastrous could happen. So aspirin has kept a generation of what we call gastroenterologists busy with ulcers and internal bleeding events. They'll be the first to tell you. But we don't have a test that's going to come up and say, oh yeah, that person's going to definitely have an ulcer, or that person's going to bleed into the brain. We don't have that test. That's why I caution people, even though aspirin looks exciting, that unless you qualify based on your cardiovascular risk, I wouldn't just pop it because you were diagnosed with cancer. We go random now, just like random Oprah in the audience, or Phil Donahue. Do people remember Phil Donahue?
I was just wondering if there was any research that showed any evidence that infection was a factor in prostate cancer.
There is actually some evidence, preliminary, of some certain chronic infection and then some virus type studies, actually a lot of studies in several places doing similar work and collaborating and corroborating each other's findings that in fact there is some evidence, but it's not, it hasn't been completely proven. It's like, haven't really identified the exact agents, but there are certain viruses, studies out of the Cleveland Clinic especially, that's been quite well publicized. But at the moment, there's nothing that we can do to prevent that, as far as we know.
The only comment I can say about inflammation is be careful. It is the greatest way to sell you product. It is the greatest way I've seen right now in North America to sell you a product that doesn't work. So it is true that inflammation can cause diseases, chronic inflammation. Chronic inflammation of the liver from a viral infection not only causes just hepatitis, but can increase your risk of liver cancer. So we have examples. We have a bug in the stomach and the intestine that chronically causes inflammation, H. pylori, that can lead to cancer there. That's true. But the problem with that is the body needs a certain amount of inflammation to repair itself. So don't let someone say, well, this cures inflammation, and then if it cures inflammation, then you get rid of the cancer. Because the problem with that thinking is that's where we got in trouble with Celebrex and Vioxx, these painkillers. They convinced the generation of doctors that, look, it reduces inflammation, so then it must reduce the risk of heart disease. So if you look at the old papers on Celebrex and Vioxx, and Celebrex is still for sale, it's a good drug, but Vioxx was removed, you would see papers from 15, 20 years ago, doctors arguing, well, it reduces inflammation, so it must reduce heart disease. And then it turns out that clearly both drugs increase the risk of heart disease. So inflammation is an interesting concept. But remember, we also need it to survive and to repair ourselves. So I just thought I would throw that consumer hook because I deal with it all the time.
Can you comment on genetically modified food, please, and what it has to do with all this, or doesn't have to do with it?
Does anyone else want to comment on that? You have a very strong voice, sir, by the way. I mean, I thought you had a microphone on. That's excellent. Were you a singer in another life?
A preacher.
Preacher, that explains it. Well, now I gotta be careful what I say. Now I gotta be careful. Well, you know, we don't mind genetically modifying everything but our food. We don't mind that our little dogs are genetically modified versions of them, and we walk around, they're cute. I have a little Shih-Tzu, mixture between a Bichon Frise and a Shih Tzu, beautiful little dogs. Genetically modified food has also come with tremendous benefits by reducing the amount of some fertilizers and pesticides that we use. So it comes, the nervous part is, are we going to create these crazy type foods that will ultimately be a problem that the body's going to have a difficulty with? I don't know yet, but I also know that it can come with tremendous benefit, and maybe we've lost some of the flavoring in our foods. I don't lose sleep about it just yet. It's like the organic situation. And the reason I don't lose sleep about it goes back to the last slide, is that I think there's already so much to worry about. I mean, life is a terminal disease. And the truth of the matter is, genetically modified food, we're keeping our eye on, whether it's soy products and other products. And you do have options now today at health food stores that you don't have to eat genetically modified foods, and those can be identified at a health food store. But my personal opinion from all the research I've seen is I'm still far more concerned on whether or not someone's had a colonoscopy. And those things concern me more. So I actually have not lost sleep yet in terms of the level of genetically modified food in our food supply. But I know in some conventions, in some lectures, someone would take the air out of my tires for that answer. It was like a couple days ago, Stanford did the largest study in the history of medicine that I'm aware of looking at the benefits of organic versus non-organic food, and came to the conclusion that it was no better. And people freaked out. But the truth is always somewhere in between, I find. We find less pesticides, less fertilizer used on organic food. It makes much more sense for the environment, but the price is not low enough now to generally recommend it to people who are more moderate or low income. It doesn't make sense. I cannot walk into Detroit and recommend a $7 carton of blueberries that are organic. It makes absolutely no sense. But now you can make so much money from organic food that Walmart and other people are getting involved, so the price is going way down. And so naturally, we're just going to move more toward organic farming. It's just going to happen. So there are certain things in health, I guess what I'm saying is I let the financial competition of the day take care of itself. So when trans fat was an issue, I told patients don't worry about it. Because just financially, there's so much political pressure, it's going to end up getting removed just because it is a problem and there's going to be enough people freaked out about it that it's just going to commercially move its way out of the system. Genetically modified food is that way. We haven't reached a critical mass. People are still comfortable with it, but I can guarantee you, if we hit several examples where something goes wrong, commercially it'll be so devastating that we'll start moving away from it. But that hasn't happened. I get asked all the time about ionized water, alkaline water systems. I was at Kaiser in West Los Angeles a few days ago. I've given a talk there for 15 years in a row. And someone came up to me and said, I'm about to buy an alkaline water system. And I said, how much are you going to pay for it? This is along the same lines of what you're asking. He said, $7,000. I said, what's your glucose level? I don't know. What's your triglycerides? I don't know. What was your last LDL? I don't know. What was your last CRP, HSCRP? I don't know. I said, okay, but I can tell you this. Let's just look at that issue. Anything that you consume, once it hits your stomach, it hits a pH of 2. It's so acidic that it could burn a hole in this rug in 2 seconds, burn a hole in this table in a millisecond. Then when it shifts in the stomach, it goes into the intestine, which is an alkaline situation. So everything that you eat starts off acidic and then moves and becomes alkaline. Then you absorb it, it goes in the bloodstream, and that's a little bit alkaline too. The body is so damn good, excuse my French, of regulating everything to a moderate range that I think we can manipulate the system, but it's really hard. Now, if the water tastes better and you're not paying that much more, and they give you a summary of what it tests, and it tests for everything you can imagine, and you're comfortable with it, that's different. But most of these water situations, including the alkaline water, I always say, just show me a basic study that shows me it's better than city water, municipal water. Show me. And they'll mention some rat study or some test tube study or some friend who had cancer. And by the way, forget that he was treated with conventional therapy. He drank this water and his cancer went away. And I can never get it. And then the companies get mad at me, but they don't understand. I spent a career trying to get these companies money to legitimize their products if they work. But a lot of people just stay away from me. They don't, even if I can get them money. So right now, to answer your question, I am not excited about leaving your city water for other types of water that can claim to make you more healthy. Look at the movement we had on bottled water, only to find out that the majority of ones came from city water that were put in bottles, and then the ones that didn't come from city water, when they were left around too much in the bottle, they clearly leaked a compound called bisphenol A into the water. Bisphenol A is an estrogen that I promise you, Canada's already made a move to ban in all baby products. So I wrote an article in the Huffington Post a few weeks ago. You can go look at it, right? Dr. Moy, Huffington Post. I said, look, I love the fact that we don't want babies to get it, but I don't want to get it either if a baby doesn't want to get it. And this has been in all the plastics. So I'm saying I wouldn't spend the money on it, personally.
So, you know, I think there's certainly a large body of evidence from clinical trials that show in men with more aggressive prostate cancer that the combination, certainly with radiation, combination of hormones and radiation work better than either alone. And so we certainly have situations where we can strongly recommend the use of hormone therapy as part of the initial treatment of prostate cancer. I think the situation where we have to be a bit more circumspect is those men where we're concerned about the prostate cancer possibly returning because of changes in the PSA after they've had treatment. And in the past, we were, in a lot of men, we might be in a rush to start hormone therapy because men would be anxious about their PSA going up and such. And we're learning that there are the side effects of hormone therapy, and it's in that situation where I think we still have a lot to learn about which men need salvage hormones and when. We have a bit more information. We know now that intermittent hormone therapy is probably as good as continuous hormone therapy in that situation. But there are other things like how fast is the PSA going up, more nuances as to better inform, can we safely withhold it or should we start it based on the threat to the man of the prostate cancer returning.
I guess I'll just add a couple things in terms of we don't see it as often, which is fortunate, that with PSA, people are seeing the doctors, and actually the prostate cancer is usually diagnosed much earlier than they were 20 years, 30 years ago, 40 years ago, when they, not infrequently, the first time they saw the doctor was when they already had their spinal cord was being compressed because the spine had collapsed because the cancer had riddled through like the first slide that Dr. Moyet showed with the spots all over the skeleton, and that was a bone scan. Things like that, we hardly ever see that anymore. But there are still patients, unfortunately, that have that, or in spite of treatment, whether they've had surgery or radiation or whatever, and they still progress. Those are patients eventually do have metastatic disease, and they do require, a lot of them do require treatment, hormone treatment. I should add that not every person that has metastatic cancer of prostate needs hormone treatment. As was mentioned, that it is an individual decision, but certainly if they have symptoms or it is progressing, then they need treatment. And I must say that most physicians, would tell you when they first start that, and if they don't, they should tell you what the side effects are, the early side effects and the longer term side effects, the early side effects and things like hot flashes, and you get lethargic, less energetic, more irritable. Longer term side effects, Dr. Moyet, I'm sure, is all listed there. There are changes in the blood, in the lower blood counts, and the osteoporosis, and the lipid levels change, and all those things are all, they should be listed. And as Dr. Moyet already mentioned, most of those things can be, we can counter those and avoid them. So, okay.
I'll tell you, you reminded me of something, because we have a paper coming out. I tell people this. I'll tell you a reason why you don't want to gain weight. Men out there, why you don't want to gain weight. Because there's not a commercial that tells you, as you gain weight, you're getting a small version of hormone therapy. And what I mean by that is, we've learned that as men gain weight, it's very toxic to the cells that make testosterone. So we looked at 40 studies over the past 30 years, and we're publishing it. 38 showed that as men gain weight, 38, this is stronger than almost any relationship in medicine, as men gain weight, their testosterone level began to drop. Which is why, these guys will probably tell you, what we're starting to see is a generation of men that when they gain too much weight, their PSAs are low, but the disease keeps going. So it artificially lowers their PSA. Because we weren't used to men carrying this kind of weight before, first of all, and it also dilutes the blood test. Call it hemodilution. They're carrying very large plasma volumes. But the other reason why we've seen more obese men, we've seen in some studies they don't respond to hormone therapy too long, is because they've probably already been getting a version of it. because their testosterone may be here, it doesn't go to the basement, but it gets cut in half with their weight gain, and so it's keeping their PSA low. You know, maybe this is when they're 30 or 40, and eventually their PSA starts to rise, but the disease is more extensive than we realize because they were actually getting sort of a self-treatment. Their testosterone was going down. In fact, as much as we see testosterone replacement therapy commercials that we see, testosterone therapy treatment, and we see a million of them, and testosterone treatment, giving testosterone to a man with low testosterone really can help a lot of men. What we should also be telling these men is one way to get your testosterone back, if you want to get it back, is just to lose a little bit of weight. And we learned that from the bariatric surgery, people that lost extreme amount of weight. We would see 100, 200% increases within 12 months when they lost huge amounts of weight. And then we said, wait a second, maybe a guy who just gains 5 kilos, his testosterone goes down. And we were seeing it. I believe in the future, men will be probably given 6 months of weight loss to see if they can get their testosterone back up. And if that doesn't work, then maybe we'll give them testosterone. But one thing men are not being told is we are seeing a very strong relationship between the weight that they gain and the testosterone that begins to be reduced. They start making more estrogen. They get in touch with their feminine side, but the reality is their testosterone's going down. So it's another reason why I tell people all the time, be careful about the weight gain from where you are. It really affects your testosterone level.
Well, thank you very much.